Welcome to AETCM, the Emergency Medicine channel. Today we are heading with the chapter ATLS, chapter 4, Thoracic Trauma. So, coming to primary survey, coming to airway problems, first we have to see whether any airway obstruction is there. So, look for swelling, bleeding, any aspirated vomitus, any laryngeal crepitus, any posterior dislocation of the clavicular head and any penetrating trauma. And look for air hunger, that is any intercostal or subcostal, supraclavicular, subclavicular, any retractions. And inspect for oropharynx for foreign body and look for stridor, as we told, laryngeal injury crepitus will be there over the anterior neck. And coming to tracheobronchial injury, it is usually it is unusual but potentially fatal tracheal bronchial injury. So, injury occur within 1 inch of the carina and it usually presents as hemoptysis, cervical subcutaneous emphysema, tension pneumothorax and cyanosis. So, diagnosis is confirmed by bronchoscopy and the immediate treatment is a definitive airway, that is the fiber optically assisted endotracheal placement mainly to the uninjured bronchus and then followed by immediate operative intervention.
So, now this has become the new life-threatening injury according to the new ATLS guidelines, right?
Oh, yes, sir.
Okay. Can you explain the other life-threatening injuries when we go passing through?
Massive hemothorax, tension pneumothorax, tracheobronchial injuries.
Flail chest is out right now, then airway obstruction, tracheobronchial injury, then pneumothorax open and tension, then traumatic circulatory arrest, tamponade and hemothorax.
Coming to the breathing problems, the main breathing problems in thoracic trauma is tension pneumothorax, massive hemothorax and open pneumothorax. So, coming to tension pneumothorax, it occurs when there is a one-way valve air leak occurs from the lungs through the chest wall. So, the air will enter into the pleural space which may cause the lung to collapse and the mediastinum will be displaced to the opposite side and it will decrease the venous return and it causes the obstructive shock. So, this is a tension pneumothorax. This is the collapsed lung and the air will circulate within that and the mediastinum will be shifted to the opposite side. So, signs and symptoms are chest pain, air hunger, tachypnea, respiratory distress, tachycardia, hypotension due to obstructive shock, tracheal deviation away from the side of injury, unilateral absence of breath sounds, elevated hemithorax without respiratory movements, distended neck veins and cyanosis. Diagnosis is by EFAS and chest X-ray. Chest X-ray we can see the pneumothorax and if there is large pneumothorax we can see the collapsed lung and by EFAS we can use a M mode. We can use C for lung sliding and C for M mode which may cause barcode sign. Usually it should be seashore sign.
So, in seashore what is the lung is?
Lung will be the shore. That movement will be there.
Okay.
And the management is immediate decompression by needle and then chest tube. So, your needle decompression is initially it was second intercostal space, now it is fifth intercostal space in the anterior axillary line just in front in the fifth intercostal space. Then coming to open pneumothorax, it is also known as sucking chest wound. So, when the opening of the wound is more than 2/3 of the trachea, circumference of trachea, then air will preferentially will pass through the chest wound. So, that is the open pneumothorax and management is 3-sided taping to provide a flutter valve effect. So, this is the open pneumothorax. Here will be the wound. So, the air will preferentially will enter into through the chest wound. Then coming to massive hemothorax, it is the accumulation of more than 1500 ml of blood in one side of the chest due to trauma. So, there are some indications for immediate thoracotomy. One is more than 1500 ml of blood when we put the chest tube. In one way it will come in 1500 or else more than 200 ml per hour it may blood come or recurrent blood transfusion will be required.
Okay.
So, it will be needing the immediate thoracotomy. So, this also we will have to put a chest tube for ventilation and fluid resuscitation with blood should be done.
Okay.
So, our usual size will be 20 to 32 French.
So, this is the new change in the newer guidelines. Earlier it used to be 36 to 40 French, right now it is changed to 28 to 32.
Coming to circulatory problems, so airway, breathing done. Circulatory problems will cause massive hemothorax, cardiac tamponade and traumatic circulatory arrest is in the circulatory problems. So, cardiac tamponade, it is like the blood accumulate in the pericardium and causes the compression of the heart which causes the decreased input, cardiac input and which may cause decreased cardiac output and then obstructive shock. So the Beck's triad in cardiac tamponade is muffled heart sounds, hypotension and distended neck veins. Diagnosis is by fast or echo probe by the pericardial window. And management is emergency thoracotomy or sternotomy by a qualified surgeon. If it is not possible, a subsiphoid pericardiocentesis can be tried using Seldinger technique. So this is a cardiac tamponade. This is the blood in the pericardial sac, and during echo, we can see the blood here. This is the coming to traumatic cardiac arrest. So the causes may be hypoxia, tension pneumothorax, profound hypovolemia, cardiac tamponade, a cardiac herniation and severe myocardial contusion. So this is a traumatic cardiac arrest algorithm. So if the patient comes with a traumatic cardiac arrest, that is without any pulse, within 2 minutes the closed CPR should be in progress. That is airway, external cardiac massage, orotracheal intubation and 100% oxygen, IV fluids by IV or IO lines and epinephrine. And if ROSC is attained, you can continue with the usual management. If there is no ROSC, then we have to do bilateral chest decompression, initially by needle and then to chest tube. And then also if there is no ROSC, within 3 minutes we have to do the androlateral clamshell thoracotomy and vertical pericardiotomy, that is if to release the tamponade. And after that you have to see for either cardiac injury or severe hypovolemia. If there is cardiac injury, repair the cardiac injury and then look for ROSC. If there is hypovolemia, look for either in thorax or abdomen. And if the thorax, the pulmonary pedicle and mediastinal vessel should be clamped. In abdomen, descending aorta should be clamped. And continue the resuscitation with IV fluids and blood. And if patient is still in cardiac arrest, do an internal cardiac massage and or internal electric shock. And the death should be declared after 30 minutes of resuscitation if the temperature is more than 33 degrees Celsius. These are the potentially life-threatening injuries, that is simple pneumothorax, hemothorax, flail chest.
This is removed right now. According to newer guidelines,
flail chest is removed. Pulmonary contusion, blunt cardiac injury, traumatic aortic disruption, traumatic diaphragmatic injury and blunt esophageal injury.
And tracheobronchial injury is added.
Added to the potential life-threatening. Simple pneumothorax and hemothorax, actually the management is same as we told.
Same thing, but in fifth intercostal space, whereas in children
it will be the needle decompression will be in the second intercostal space.
And the triangle of safety, where is
triangle of safety? The anteriorly will be the pectoralis major and posteriorly will be the latissimus dorsi, and base of the triangle will be the fifth intercostal space. And coming to flail chest and pulmonary contusion, the flail chest is defined as the rib fracture, which is 2 or more rib fracture fractured in 2 or more places. And pulmonary contusion is a bruise of the lung caused by the thoracic trauma, and blood accumulate with the lung tissue and it may cause hypoxia. Diagnosis is like there will be paradoxical respiration, that is during inspiration the flail chest component will go in and during expiration it will go out. And we can feel the crepitations of the ribs due to subcutaneous emphysema. The diagnosis is by chest X-ray, and management is mainly by humidified oxygen, adequate ventilation, analgesia, so that the patient will prevent the lung collapse, and then fluid resuscitation. And if there is significant hypoxia, we have to intubate and ventilate the patient. Coming to blunt cardiac injury, there is a result in myocardial muscle contusions and cardiac chamber rupture, coronary artery dissection, thrombosis and valvular disruptions. The signs and symptoms will be like chest discomfort, hypotension, dysrhythmia, and echo will be showing RWMA. And coming to traumatic aortic disruption, it should be suspected in whether there is persistent or recurrent hypotension even after resuscitation, and ruling out other causes of shock. So the radiographic signs will be widened mediastinum, obliteration of aortic knob, deviation of trachea to the right, decompression of left mainstem bronchus, elevation of right mainstem bronchus, obliteration of the space between pulmonary artery and aorta, deviation of esophagus to the right, widened paratracheal stripe, widened paraspinal interfaces, presence of pleural or apical cap, left hemothorax, and fractures of first or second or scapula. So diagnosis, if stable, we have to go for CECT or aortogram, and other mode is transesophageal echocardiography. The management is IV analgesics, and if there is no contraindication, control the heart rate with beta blockers less than 80 and BP with a map of 60 to 70 mm of mercury. And the management is by open repair, resection and repair of the injury. Then coming to traumatic diaphragmatic injury, it is more common on the left side. The blunt trauma may cause large radial tears that lead to herniation. Penetrating trauma produces small perforations. So, it is frequently missed in initial chest prelims. So, if it is inconclusive, we have to go with CT with upper GI contrast study, and the treatment is direct repair. Coming to blunt esophageal rupture, it may be caused by a forceful expulsion of the gastric contents as a result of an abdominal trauma, so that it will the linear tear will allow the contents to leak into the mediastinum, causing rupture into pleural space, and it may cause empyema in the long run. So, the diagnosis is presence of mediastinal air, which is confirmed by the contrast studies and esophagoscopy. And management is wide drainage of the pleural space, since if there is empyema, and mediastinum with the direct repair of the injury.